I gave an educational on sequencing multiple myeloma therapies. I mentioned and I showed that at this moment we have an increasing number of drugs available to treat multiple myeloma patients. We have proteasome inhibitors, we have IMiDs, we have steroids, we have alkylators, we have antibodies, we have antibody drug conjugates, we have XPO1 inhibitors approved in the US, and several very promising drugs are coming up soon, not only cell mods, but also bispecifics and CAR T cells. So the number of drugs available is increasing. And also the ways of combining all these different agents is increasingly complex because there are so many options. And also the sequencing of the different treatment options during the patient's disease course is also increasingly complicated. So in my talk, I tried to describe how doctors can use myeloma drugs best, when to use them, which combinations to use them, and in which sequence to use them. So one of the important changes in the myeloma field is that lenalidomide, for example, is increasingly used up front because we give elderly patients Lendex or fit elderly patients VRD. We give transplant-eligible patients Len maintenance, and in the nearby future, also the use of CD38 antibodies will further increase. Because Len is increasingly used in first line, we will encounter an increasing proportion of patients with lenalidomide refractory disease at the time of first relapse. So the first part of my presentation was about how to treat first relapse. And this is not only based on patient characteristics, tumor characteristics, availability of drugs, but also based on whether the patient is progressing on Len or is Len sensitive or Len naive. So if the patient is Len naive, then most doctors suggest to use a Len-based triplet or sometimes a doublet when the patient is frail. And we have now 4 Len-based triplets available, which are more active than Lendex. And these triplets are Dara Lendex, Elo Lendex, carfilzomib Lendex, and ixazomib Lendex. And when the patient has never received daratumumab, I favor to use Dara Lendex at the time of first relapse, because this regimen has the best hazard ratio, has a favorable tolerability profile, and median progression-free survival is like 4 years or more. So I favor a Dara-based Lendex combination at the time of first relapse in Len-naive patients. However, when the patient is refractory at the time of the first relapse, then a Len-based triplet is probably not the best choice. These patients were, for example, not enrolled in the studies, and it's better to switch class. So patients that have Len refractory disease may benefit from a bortezomib-based triplet like Dara-VD, a carfilzomib-based triplet like Dara carfilzomib dexamethasone or isatuximab carfilzomib dexamethasone, or they can benefit from a pomalidomide-based triplet such as Dara Pomdex or PVD, Pomveldex. So Len refractory patients have several options: board-based, carfil-based, or Pom-based. And when they are frail, sometimes a doublet is still the best option, because you do not want to give frail patients too much toxic drugs, because toxicity adverse events will lead to treatment discontinuation, which has a negative impact on survival. So after having presented first relapse, I also briefly discussed how to manage double refractory patients. These patients can be treated with a Pom-based regimen or a carfilzomib-based regimen, in combination with drugs that were not given before. And eventually the patient becomes triple class refractory. And these triple class refractory patients can benefit from selinexor, which is recently approved. Triple class refractory patients may also benefit from belantamab mafodotin, which is recently approved. And these drugs induce a 30% response rate in triple class refractory patients. But these patients may also be enrolled in clinical trials. where they can benefit from very promising drugs such as bispecific antibodies, CAR T cells, which induce responses of more than 70% in triple-class refractory patients. Other agents that are being evaluated in clinical trials are CELMoDs, like iberdomide and CC480, melflufen, venetoclax, and many others. And when a clinical trial is not possible, when an ADC like belantamab is not possible or selinexor is not available, then you can always recycle drugs that were given before in different combinations. And finally, what I also mentioned is that daratumumab is increasingly used upfront. So we have now, for elderly patients that are not transplant eligible, Dara-Lendex approved. We have Dara-VMP approved, and also transplant eligible patients can be treated with a Dara-based regimen like Dara-VTD. I favor to use the best drugs up front because I want to induce the deepest remission possible, as that translates to the best survival and hopefully also cure, because the patients that survive more than 20 years without relapse is increasing more and more with the use of good drugs up front. And I favor to use good drugs up front because a substantial number of patients will never receive second-line or third-line therapy because they die of myeloma or treatment-related complications. So to save a drug for later can be a mistake. So I like to use the best drugs up front. So a combination of proteasome inhibitor, lenalidomide, and daratumumab is commonly used in newly diagnosed patients that I see in my clinic. And that also means that at the time of first relapse, patients will not only be exposed to lenalidomide, but also be exposed to daratumumab. And that's also something that you have to take into account when you pick a relapse regimen at the time of first relapse. So if the patient is relapsing on daratumumab, then we have no data at this moment available of whether we can continue daratumumab, and it's best to pick a regimen without daratumumab because there is no evidence of cross-resistance between dara and other anti-myeloma agents. Studies are ongoing that will show in the nearby future whether retreatment with a CD38 antibody with a treatment-free period of 3 months is beneficial for the patients. And this treatment-free interval of 3 months is chosen because it takes approximately 3 months before CD38 expression is restored on myeloma cells and NK cells are back to baseline, because CD38 goes down upon initiation of daratumumab, and also NK cells go down upon initiation of daratumumab. And it takes a couple of months, 3 to 6 months, before CD38 and NK cells are back, and that's why the LYNX study has this 3-month treatment-free interval. So important studies that will learn us more about the potential of daratumumab retreatment. And another open question is the retreatment with BCMA targeting agents. Can we switch from one agent targeting BCMA to another BCMA targeting agent with another mode of action? Several cohorts, several studies are enrolling patients with prior BCMA exposure to study whether retreatment with a different BCMA targeting drug, a bispecific, an ADC, or CAR T is possible. And correlative studies in these trials will also inform us about why patients relapse on a BCMA-specific agent, and maybe also inform us on whether that has an impact on the potential of retreatment. That was, in short, the educational that I give, the contents of the educational that I give in this ASH 2020 myeloma session.